So today we will talk about Leishmaniasis, another protozoal disease that is caused by Leishmania donovani and other Leishmania also. Leishmaniasis is a disease of poor people, mostly spread in India, Sudan, Kenya. These are the type of countries where we get Nepal, where there is a lot of prevalence of Leishmaniasis. In India, this is found in states like eastern part of UP, Bihar, West Bengal, Jharkhand. Mostly the cases are concentrated in Bihar. As I said, this is caused by the main problem with Leishmaniasis is visceral Leishmaniasis that has a lot of mortality. Other types of Leishmaniasis, they are not that lethal. We'll talk about the types, but visceral Leishmaniasis, and even now, almost if you say 10 years back, almost 50 to 90,000 cases are reported every year in the world, and out of them 90%, almost 90% are centered in India. So this is a disease that needs to be taken care of. See, Leishmaniasis is caused by, as I said, Leishmania donovani, transmitted by female sandfly Phlebotomus species. In the fly, the organism is flagellate extracellular. We call it promastigote. But in the human being, this is found in macrophages, non-flagellate form. That is known as a mastigote. Another types of Leishmaniasis are cutaneous, that is caused by Leishmania brasiliensis, and cutaneous Leishmaniasis, that is caused by Leishmania tropica. They have different symptoms. Like these are three main types of Leishmaniasis. One is cutaneous, mucosal, nose and mouth are damaged, and visceral, that is life-threatening organ damage. In cutaneous Leishmaniasis, this is the most common type of Leishmaniasis, but it is less common in India. This form affects the skin, usually developing as sores within weeks or months of an infected sandfly bite. Starts as painless papules or nodules at the bite site, often evolves into ulcers resembling a volcano with raised edges and a central crater, and may be covered by a scab. Swollen lymph nodes may appear near the sore. Sores heal in months to years, leaving permanent scars. Something like this. This I have taken from Google, DermNet. So this is cutaneous type. Then we have visceral Leishmaniasis, severe, systemic. This life-threatening form affects internal organs like spleen, liver, bone marrow. These are the organs which are affected. Appears within 2 to 8 months after the bite. Irregular bouts of fever can last for months, come in cycles, 3-day fever we call it. Significant enlargement of the spleen and liver, leading to a swollen or distended abdomen. Substantial weight loss, extreme weakness and fatigue cause severe anemia and low platelet counts, making the skin look pale. The disease causes darkening or discoloration of the skin in some patients. That is why it is called black fever, or in India we call it Kala-azar. We also call it Kala-azar, but basically the local slang is Kala-azar. Azar means fever. This is how the person looks like. Then third is mucocutaneous Leishmaniasis, less common. This form can occur when cutaneous infection spreads and damages tissues in the nose, mouth and throat. There is stuffy or runny nose, nose bleeds and ulcers on the inner nose, erosion and wearing away of the mucous membranes in the mouth, gums or palate which can be highly disfiguring. Damage to the larynx and surrounding tissues can cause hoarseness and severe swallowing difficulties. Something like this. The skin lesions, they can spread to mucous membrane also. What do we have for treatment? The classical drug is Sodium Stibogluconate. It's a pentavalent antimonial medication primarily used as the first line treatment for all forms of Leishmaniasis, visceral, cutaneous and mucocutaneous, all. Antimonial, pentavalent. So this was the mainstay when before say 30-40 years when we were undergraduate, this was the mainstay of therapy. This was the drug of choice. But now gradually, if you see the resistance to this drug, particularly in India and Nepal, in Bihar almost 60% of the patients, they are resistant to sodium stibogluconate. So in India it is no more the drug of choice, but we are covering is in the beginning because we always prepare for short notes, and this is an important drug. The short note may be there. Macromolecular disruption, this is the mechanism of action. It causes a significant decrease in parasite DNA, RNA, protein and purine nucleoside triphosphate levels. It decreases the viability of the Leishmania parasite by inhibiting its glycolysis and the citric acid cycle, starving it of crucial energy. So enzyme inhibition is there. Energy depletion. It actively suppresses the synthesis of ATP and GTP, which further prevents the parasite from repairing and multiplying. So enzyme inhibition decreases the viability of the Leishmania parasite, inhibits glycolysis and citric acid cycle, and inhibits the synthesis of ATP and GTP. Also significantly decreases parasite DNA, RNA, protein and purine nucleoside triphosphate levels. So this is the mechanism of action. Visceral, these are the indications of sodium. There is no other indication of, remember, sodium stibogluconate. This is a specifically anti-Leishmaniasis drug. So visceral Leishmaniasis, Kala-azar, treatment of systemic Leishmaniasis infections that affect internal organs. Remember, in other countries this is still the drug of choice. Cutaneous and mucosal Leishmaniasis, treatment of skin ulcers and mucosal tissues affected by the parasite. So these are the indications of sodium stibogluconate. Adverse effects, common adverse effects are nausea, vomiting, diarrhea, loss of appetite, fatigue, headache and muscle or joint pain. Localized pain, swelling and irritation at the injection site. This is an injectable drug. Serious side effects is pancreatitis, highly common, elevated amylase lipase. Second is cardiotoxicity, can cause ECG changes such as flattened or inverted T waves and prolonged QT intervals, and in rare cases arrhythmias. Hepatotoxicity and nephrotoxicity, liver enzymes and kidney functions can be elevated during treatment. Increased creatinine levels. Bone marrow suppression may lead to leukopenia or thrombocytopenia. Remember, the drug is contraindicated in patients with severe cardiac, liver or renal disease and should be used with extreme caution during pregnancy. Second drug, and that is actually the drug of choice in India, is Amphotericin B. It is a broad spectrum poline antifungal. See the complicated structure, poline antifungal. How does it act? It binds to ergosterol, forming cylindric like cluster, tetramers and octamers in the lipid bilayer. And then what will happen? Multiple amphotericin B molecules cluster together to create transmembrane pores or ion channels, we can call them. So this drug is forming cylindric like clusters, tetramers and octamers, and then many of these tetramers and octamers, they are coming together to form these ion channels, these pores. Ion and metabolite leakage. Vital electrolytes like sodium, potassium, hydrogen ions, chloride, and small metabolites leak out through these ion channels. A massive influx of protons occurs, causing a fatal acidification of the parasite's cytoplasm. The drug also triggers the accumulation of reactive oxygen species and reactive nitrogen species, further damaging the parasite. This is the indication. Acts as a gold standard or reference agent for treating severe invasive mycosis such as cryptococcal meningitis, histoplasmosis, aspergillosis, blastomycosis, and mucormycosis. So amphotericin B is primarily an antifungal drug. Empirical therapy is frequently used as an empirical treatment for fever and suspected fungal infections in severely immunocompromised or neutropenic patients. So all these types of fungal infections, invasive mycosis such as cryptococcal meningitis, histoplasmosis, aspergillosis, blastomycosis, and mucormycosis, for treatment and for prophylaxis in severely immunocompromised or neutropenic patients. So primarily an antifungal drug. It is an FDA approved treatment for visceral leishmaniasis. Visceral leishmaniasis. That is a very serious disease, very problematic disease. That is Kala-azar. So remember, it's not that leishmaniasis is known as Kala-azar. Cutaneous, mucocutaneous leishmaniasis, they are not Kala-azar. Kala-azar is visceral leishmaniasis. That causes, as we talked about, extended abdomen and discoloration of the skin. That is why we call it Kala-azar. Amphotericin B is primarily administered via IV infusion and is available in conventional and lipid-based formulations. Liposomal amphotericin B is preferred. Delivered directly to the site of infection, significantly reducing nephrotoxicity. What happens? It is notoriously nephrotoxic. Most patients experience some degree of kidney impairment, though it is often reversible. Causes significant potassium and magnesium wasting, leading to hypokalemia and hypomagnesemia. Elevated blood creatinine and reduced kidney function. Tubular acidosis due to improper kidney function. So this is a very toxic drug. Sodium Stibogluconate also, we talked about that, this causes kidney damage, this causes nephrotoxicity. Infusion related reactions, these typically occur 1 to 3 hours after starting the intravenous drip and are usually most severe during the first few doses. What happens? There are fever and chills, very common, often called shake and bake. Nausea and vomiting, GI distress is widely reported. Headache and dizziness frequently occur during or shortly after administration. And cardiovascular and respiratory problems, there is hypotension, there is tachycardia and shortness of breath. So these are infusion related reactions. Then blood and nervous system. What happens? There is anemia, common due to suppression of red blood cell production. Nerve symptoms like peripheral neuropathy is rarer but possible. Seizures are rare but serious neurological risk. And other potential side effects are injection site pain, thrombophlebitis, Allergic reactions, rashes, itching, or severe anaphylactic reactions, though it is rare. So these are the side effects of amphotericin. One is kidney and metabolic damages. We have talked like this is nephrotoxicity occurs in all cases depending on how long the treatment is taken. Then these are infusion related problems and blood and nervous system. They are all these problems. Allergic reactions. Then another drug is miltefosine. It is hexadecylphosphocholine. It is an alkyl phosphocholine drug. It is an essential orally administered synthetic ether lipid primarily used to treat parasitic infections like Leishmaniasis and free-living amoebic infections. It is noted for being the only approved oral therapy for visceral, cutaneous and mucosal Leishmaniasis. So see, it is a this molecular structure consists of a long lipophilic 16 carbon alkyl chain, and that is attached to a polar hydrophilic phosphorylcholine head group. It is a deuterium containing both positive quaternary ammonium and a negative phosphate. This is quaternary ammonium positive and this is phosphate group that is negatively charged, which are attached to a long lipophilic 16 carbon alkyl group. Precise mechanism is not known. Multi-layered disruption of the parasite's cellular functions occur. How? Number one, membrane and lipid disruption. It interferes with the biosynthesis of phosphatidylcholine, a crucial lipid the parasite needs to maintain membrane integrity. So what is it affects? It affects phosphatidylcholine. Apoptosis induction. It triggers apoptosis like cell death by disrupting mitochondrial function, inhibiting cytochrome oxidase and altering acidocalcisomes, which are critical for energy production and calcium homeostasis. Acidocalcisomes. Signaling interruption. In cancer cell lines, it inhibits AKT, halting cellular pathways involved in growth and proliferation. So these are the mechanisms. One is membrane and lipid disruption by inhibiting biosynthesis of phosphatidylcholine. Then it causes apoptosis induction by inhibiting cytochrome C oxidase and altering acidocalcisomes, and it also inhibits AKT, halting cellular pathways. So this is the mechanism of action of miltefosine. This is becoming gradually an important drug. Indications: Leishmaniasis. It is a first line therapy for visceral Leishmaniasis, that is Kala-azar. Cutaneous and mucosal Leishmaniasis caused by various Leishmaniasis species. So this is effective against all types of Leishmaniasis. Free living amoeba. The CDC recommends it as an off-label frontline therapy for life-threatening brain infections including primary amoebic meningoencephalitis caused by Naegleria fowleri, Naegleria fowleri, and granulomatous amoebic encephalitis. So this is an important drug for these free-living amoeba. Gastrointestinal distress. These are the problems that we face. The most frequent side effects include nausea, vomiting, diarrhea, and abdominal pain. Taking the medication with food significantly improves absorption and minimizes these symptoms. Teratogenicity causes severe birth defects and embryotoxicity. Strictly contraindicated in pregnant women and female patients of childbearing age must use effective contraception during and for months following the therapy. Organ toxicity. It can reversibly elevate liver transaminases and causes renal impairment. Again, nephrotoxicity and hepatotoxicity. Other effects: mild to moderate headaches, dizziness and pruritus may occur. That is seen with all these drugs. Then we come to what are the recommended regimes for leishmaniasis. For visceral leishmaniasis, that is Kala-azar. Actually in India we are mostly concerned with this only, not about cutaneous, because that is not a very serious disease and mucus lesions are not that common. So this is the main problem in India. Amphotericin B deoxycholate 0.75 to 1 milligram per kg IV infusion over 4 hours daily or on alternate days till a total of 15 milligram per kg. We have to remember this regime. Amphotericin B deoxycholate 0.75 to 1 milligram per kg IV infusion daily or on alternate days till a total dose of 15 milligram per kg is administered. Then liposomal amphotericin B 3 to 5 milligram per kg IV infusion daily for 3 to 5 days, again a total dose of 15 milligram per kg, but we can administer larger doses so the duration is decreased. Or liposomal amphotericin B 10 milligram per kg single dose infusion if the patient can tolerate. So these are two regimes. One is amphotericin B deoxycholate 15 milligram per kg total dose daily. Second is liposomal amphotericin B, again 15 milligram per kg total dose over a period of 5-6 days. And third is miltefosine oral with meals for 28 days. What is the dose? In adults more than 12 years, weight more than 25 kg, we have to give 50 milligram twice daily. So 100 milligram daily. In adults more than 12 years, less than 25 kg weight, we have to give 50 milligram once daily. Children 2 to 12 years, 2.5 milligram per kg per day. So total duration 28 days. More than 25 kg weight 100 milligram per day, less than 25 kg weight then 50 milligram daily, and in children 2 to 12 years 2.5 milligram per kg per day. Then next regime is paromomycin sulfate. We have talked about paromomycin in amoebiasis. Paromomycin sulfate 15 milligram per kg per day intramuscular for 21 days. This is one of the regimes. Another regime is Sodium Stibogluconate. Remember, as I told you 30 years back, this was the drug of choice. So this was the primary regime. 20 milligram per kg intramuscular or slow IV daily for 30 days. 20 milligram per kg. This is available as 10% solution, that gives 100 milligram. This is the combination therapy that can be used. One is combination of liposomal amphotericin B 5 milligram per kg IV single infusion plus miltefosine in the doses that we have talked about, 50 or 100 milligram per day depending on the weight, for 7 days. Remember, if we are giving only miltefosine, then we were giving it for 28 days. But if we give it with a single injection of liposomal amphotericin B 5 milligram per kg IV, then the duration is reduced to 7 days. Another combination is liposomal amphotericin B 5 mg per kg IV single infusion plus paromomycin for 10 days. Paromomycin 15 mg per kg per day for 10 days. So remember, paromomycin sulfate alone was being given for 21 days as per regime. But now the duration will be reduced to 10 days with a single injection of liposomal amphotericin B. Then third is miltefosine plus paromomycin for 10 days. Miltefosine again the same dose, 50 or 100 mg depending on the weight, and paromomycin 15 mg per kg per day for 10 days. This is another combination regime. Then this is one problem, post Kala-azar dermal leishmaniasis. This appears after around 2 years of treatment with Kala-azar. This appears, and they are maculopapular nodules, hypopigmented nodules over upper trunk, arms, torso. Normally it is not a problem, but aesthetics, there are over face also, there can be these nodules. So what we do, liposomal amphotericin B 5 mg per kg per day IV infusion 2 times per week for 3 weeks. So total 6 doses, that means 30 mg per kg total dose. Or we can give miltefosine 100 mg oral per day for 12 weeks. Or we can give amphotericin B deoxycholate 1 mg per kg IV infusion 60 to 80 times over a period of 4 months. So these are the regimes that can be followed for that. Another is cutaneous leishmaniasis. We have talked about cutaneous or even mucosal. So what is there? Sodium Stibogluconate infuse 2 ml around the ulcer, if it is only cutaneous or mucosal. In mucosa we cannot give naturally. If it is mucocutaneous, then around the cutaneous we have to give. Paromomycin 15% ointment, apply twice daily for 20 days. Remember, like I said, if it has been widespread, mucocutaneous, skin as well as mucosa and larynx and everything is affected, then we have to treat it like visceral leishmaniasis. The regime still remains. If nothing works, then we have to go for the regime of visceral leishmaniasis. There are some problems, some issues like leishmaniasis with HIV. That is also important. Remember, they potentiate each other. In presence of leishmaniasis, HIV becomes AIDS. Actually, if there is leishmaniasis in HIV positive patients, then we call it AIDS. And the prognosis of leishmaniasis in HIV positive becomes bad and worse. So otherwise the regimes and everything, they remain same. We have to continue with anti-HIV, antiretroviral therapy, and we have to give these regimes. But the prognosis becomes less favorable in those cases. So this is about leishmaniasis. We will have some more lectures on these anti-protozoals like malaria we will have in future.